Hello, I'm Rebecca Collins-Cronkright, a PGY3 at Mercy Health in Rockford. The case that I'm presenting is important because it involves a condition that few people consider outside of alcohol consumption, Wernicke's encephalopathy. Our patient presented to ED due to a fall, along with vague nonspecific symptoms lasting over the past 2 to 3 months of progressive abdominal pain, nausea, and vomiting. Her family also mentioned that she had become more forgetful and irritable. She had several healthcare visits prior to this presentation, but her workups were largely unremarkable, and providers were mostly concerned for progressive dementia that was causing increased frailty. When she came in, we saw that her BMI was quite low, but her family said this was normal. She had always been too thin. She was oriented to person, place, time, and situation, but was slightly confused about recent events surrounding her health. Lab results were significant for hypokalemia, hypomagnesemia, and hypophosphatemia. She was admitted to replete and monitor her electrolytes. Comprehensive testing, including EGD, colonoscopy, CT, abdomen, were all largely unremarkable, save for general gastritis. As she was hospitalized, her condition worsened. It wasn't until we noticed, number one, hallucinations, and number two, nystagmus, that Wernicke's was considered. As it's a clinical diagnosis, she was started right away on treatment dose thiamine through IV, 500 milligrams 3 times a day, followed by 250 milligrams twice a day for 5 days. She recovered quickly, and by the time she left at discharge, she was able to eat, able to walk without aid. She had been using a walker for a month prior to admission and had lost her confusion. She also had a follow-up 3 months after with our GI doctor, and all her symptoms had resolved and she had actually gained weight. This is a really important case because so few of us know the initial signs of thiamine deficiency, which include abdominal pain, nausea, and vomiting. Once you have that abdominal pain, nausea, and vomiting, it makes it even harder to absorb thiamine and even ingest thiamine. So it's a vicious circle. It just compounds the issue. If the patient would have been treated prior to coming in, she would have avoided these symptoms altogether, these worsening symptoms altogether, or even in our ED, she would have not had to go through the extensive testing that she went through as she was hospitalized. It's also important to remember how big of a role thiamine plays in our metabolism. It's important at every step of turning glucose into energy for our body to use. Without the thiamine, we miss out on aerobic energy production and also making important precursors for DNA synthesis. I've included a chart that shows the important role of the biologically active thiamine in our cellular metabolism. Populations that are at risk are not just alcohol, but also anybody with decreased absorption, increased metabolic need. This includes sepsis, refeeding syndrome, ketoacidosis, pregnancy, reduced intake, drugs, especially diuretics and furosemide in particular. This is really important for our heart failure patients. And then also always suspect it in any kind of vitamin or mineral deficiency, especially magnesium. Thank you, and if you have any other questions, please feel free to reach out.